work on teams. And when you send people into teams, it goes a bit mad as well, waiting. Here we go. Hello, everyone. I hope you can all hear me. My name's Sarah Sleet, and I'm the Chief Executive of Crohn's and Colitis UK. Welcome to everybody who's joining us on our latest live stream, Facebook live stream. We have taken the topic of diet because we know at the charity one of the most frequently asked questions is all about diet and how people can help to control their own symptoms by adjusting their diet. And yet it's one of the areas that's actually hardest to talk about in many ways, because there's not necessarily clear-cut answers on how you approach your diet. It's so individual. So we're going to dive into this slightly messy topic, but really interesting one tonight. And I've got an excellent panel who are going to provide you some insights and some expertise. And we're going to hear from Katie, who's going to be coming up first, who is a dietitian, a specialist dietitian in this subject area. And then we're going to move on to Sham, who is a gastroenterologist with a special interest in nutrition. And then I'm going to be joined by Isabel, who is a nurse consultant and one of our long-term friends at the charity, who's been working with the charity for many, many years, sharing her expertise. And then, probably most importantly, we have two people who are living with Crohn's and colitis, who are able to talk about their personal experiences and insights into how diet works for them and what tips and help they can provide to you. So we're going to kick off with Katie, and perhaps if you can just give us a quick intro and some of your observations, Katie. Over to you.
Hi everyone, my name is Katie Keeter. I've been working with patients with inflammatory bowel disease for 11 years now, so hopefully I've got quite a good bit of knowledge and experience in this subject area. I think it's actually a really exciting time to be a dietitian working in this area. There's loads of research coming out. We're hopefully getting to a point where we have got some dietary therapies we can use to manage inflammatory bowel disease, which hopefully we can talk about a little bit later. One of my special interests is partial liquid diets in maintenance of remission, which again, we hopefully will touch on a bit later. I've been fortunate to do a bit of research in that area while I've been working at UCLH. Oh, sorry, pop-up just came up there. Yeah, so I'm really pleased to be here, and thanks for inviting me.
Thanks, Katie, no worries. Sham, over to you.
Thanks very much. Hi everyone, I'm Shamim. I am a gastroenterologist at the Royal London Hospital in East London. I used to be working at UCH with Katie for a few years prior to that. And like many of our patients and IBD professionals, I think that food and diet and nutrition is really important in IBD. And I guess my observations are, if we take a step back and we think about the causes of IBD, which are sort of genetics, the immune system, gut bacteria, and the environment. We've had loads of studies, fantastic studies of genetics that really improved our understanding of IBD, but it's also told us that genetics really only goes so far. It only tells us part of the story. And that's similar with the immune system. I mean, it's also an amazing time to be an IBD physician. We've got some amazing drugs coming up over the next few years. We've had a few extra drugs the last few years, but the main problem with these drugs is that although they are effective, they're not effective for everybody. And some people can lose response over time. In terms of gut bacteria, again, we are getting some really nice big scale studies over the next few years, which will hopefully give us some more information about personalized nutrition and personalized therapy. But we're quite a way off the results of those. And so then we're left with environment. And actually, we know that environment's important. We know that IBD is increasing across the world, where people are eating differently and living differently. And I think, therefore, it's probably the most under-researched and under-studied area of all of those 4 blocks. But that is changing, as Katie says. There's some lots of interest now in some really good, well-conducted and well-designed trials. So I'm really excited about the results over the next few years. But I think my last point here is that there are challenges that remain, and I think the challenges are that IBD is not one treatment. It's not one disease. There are multiple different situations in which food and diet are likely to be important. We know there's quite a lot of diets with limited evidence base. And of course, not everybody has access to people like Katie and IBD dietitians across England. So I think it's really important that we continue this conversation. So hopefully we can get into some of that with the panel over the next hour or so.
Fantastic, thank you, Sham. And now to hear from Isabel.
Good evening, everybody. I'm Isabel. I'm a nurse consultant in gastroenterology at the Royal Free, which is in North London. But I'm here really representing IBD nurse specialists, and probably most of you will have contacts to an IBD nurse specialist. And one of the things we do all the time, I've just been thinking about my day today. I have a team of us here, and we answer emails and we answer calls and we see people in clinics, and so often the conversations are not particularly about what the evidence around diet are, but just as individuals, how you can use diet to give yourself more control or to feel that you can make a difference to what you experience day in, day out. And they're often quite difficult conversations because there isn't, as Sham said, there isn't always evidence for what people want to do day in, day out. And often it's just talking through individual things. And so IBD nurse specialists are around and doing that all the time. And hopefully my addition to the panel will help reflect that as we go through. Thanks.
Thank you, Isabel. And we're going to move next to Nell. And Nell, I know that you need to leave a little bit early in the middle of the session. So we'll try and make sure that we get to you in questions earlier on. But if you'd like to give us a bit of an intro to you and your insight.
Yeah, sure. So I'm Nell Gordon. I'm a recipe developer, but I also suffer from ulcerative colitis, and I've had it for 12 years now, so a long-term sufferer. So when I was first diagnosed, I wasn't very knowledgeable about what I should be eating or how much diet affects my ulcerative colitis. But as I've gotten older and lived with it for longer, I've realized like how important it is for me, and worked out well, roughly it's just a journey and I still don't know completely, but worked out what's good, what's not good. And my recipe development kind of helps me make meals interesting and find new ways to cook with different ingredients and the ingredients that I can eat. So yeah, but I'm excited to learn things from you guys.
Fantastic, great. Okay, thank you, Nell. Over to Lizzy then.
Hi, I'm Lizzy. I was diagnosed with ulcerative colitis in January 2020. So I'm only a few years in. I was 25 when I was diagnosed. I've been on different medications, I've been on steroids, but I think diet is one of the biggest changes that I've made to my life, and as is probably the biggest change that colitis has kind of caused to my life as well. So I'm totally dairy and gluten free. It's taken me it's taken me the 2 years to get to that point. There's a few other things that I'm wary of, wary of eating too much fiber, too much green vegetables, spicy food, things like that. But it has been a tough 2 years to get there, but I feel like I'm in quite a good place with it now. Not every day, some days are better than others, but I feel like I've been on quite a journey with it, and I kind of in a good place with it now.
Great, thank you, Lizzy. Okay, so we wanted to make most of this session this evening about questions and getting a conversation going around this important topic. But we're going to just kick off with a very, very broad question aimed really at Sham and Katie. And I think, Sham, you've already sort of alluded to some of this, but in general, what is, do you think, the link that we know about between diet and Crohn's and colitis? So what do we really know at this stage? Shall I start with Katie first and then go to Sham?
Yeah, I mean, I think the easiest way to answer that is probably to look at the change in the trends of consumption. So we know that the incidence or the number of people that are developing inflammatory bowel disease has greatly increased in East Asia, Africa, India. So there's been quite a great interest in looking at research in those areas and what's actually caused the increased trend in developing inflammatory bowel disease. And we know now there's a strong link between what we call a westernized style way of eating. So the changes in consumption has mirrored the more westernized hemisphere. And what we mean by westernized style of diet, so higher consumption of processed foods, prepackaged foods, higher intake of fizzy drinks, lower intake of fruits and vegetables, so like more of a low fiber diet, more refined carbohydrates. And studies which have followed people up to find out who develops inflammatory bowel disease have found there's a definite link or a higher risk in developing inflammatory bowel disease in people who follow those types of diets compared to a diet which is high in fruit and vegetables, high in fiber, and low in refined carbohydrates. So we can't say it's purely causational, but we know there's a definite link there. And I would say that's probably one of the drivers to the high amount of research now in Japan, China, in Asia, because of the increased incidence, really.
That's really interesting.
And I think Shamir had already mentioned that there has been some research that showed that there is effects on the gut. I think it is, you do need to be a bit careful though, because a lot of the research is in animal models. So a lot of the research that has shown the harmful effects of these food components has actually been studied in rice and rice, not rice, sorry, mice, mice and rats. So I do think we do need to be careful how we interpret the information as well, but there definitely does seem to be a link there. I'm sure that Shamir can provide a bit more information on that side of things too.
Thank you. I mean, that's really interesting, you know, that rise in prevalence in those areas and starting to link it to the types of diet. But we're so early on this understanding, aren't we?
Yeah, yeah.
Yeah. Sham, what would you add to that?
Yeah, I mean, I agree with all of those points. It's quite complicated. So there's certainly some older studies, exactly as Katie suggests, that describe that, you know, fiber is important. We know that certain is important as well. And there are some newer studies that also focus on kind of smaller things, so food additives, so emulsifiers, preservatives, all of those things. And I think Katie's right to be a bit cautious about this because it's quite complicated. There are also some studies that don't show those effects. And many of these studies use things called food frequency questionnaires. So you've got to, well, how do these studies actually get this information? Well, essentially what they're doing, they're asking people to fill in questionnaires about what they've eaten either now or at some point in the past. And I think the thing with diet, which will probably kind of seep into the rest of our conversation, is that the devil's very much in the detail. So if you say, I've had bread, you know, there are different brands of bread. There are different brands that have different, you know, sweeteners, preservatives, they're processed in different ways. And all of that is very likely to be relevant in patients with IBD. So I think there are some studies, they give us an inkling. We need to be a little bit cautious about how we interpret them. And the other thing I might say about this is that some of these foods also have other health benefits, right? So ultra-processed foods, for example, also include things like tin foods and cereals. And these are, you know, they've got fiber, they are cheap, they're easy to prepare, they're energy dense. You know, we're living at a time where the cost of living is going up. So we need to be a bit careful that we don't just focus on IBD and we sort of think about patients overall. But in terms of IBD, those are, as Katie mentioned, you know, sugary foods, certain fats, fibers, and ultra-processed foods seems to be important. the good news is that there are some really good trials happening. So there's the ADAPT study happening at King's, which is looking at exactly this, a really well-designed study that kind of takes away some of the problems from previous kind of dietary studies. So I would hope that next time you do a Facebook Live on diet and IBD, we'll be a bit better informed.
Okay, we'll invite you back to that one. Sorry, Katie, go ahead.
The only thing I would add to that in terms of sort of processed food, prepackaged foods, is we do know there's very key additives, so emulsifiers, artificial sweeteners that potentially promote inflammation. So it's not that you have to necessarily avoid all prepackaged food or all processed food. When I'm educating patients, I do try and educate them on the key ones that they may want to look out for. Just as Shamim said, just to make sure the diet doesn't become too restrictive and too difficult to follow as well.
That's a really important point, that we don't want people to sort of leap to, I must take everything out of my diet, I must take, because, you know, actually a very restricted diet can be as problematic.
Yeah, exactly.
Yeah. We're talking about how do people identify whether they have got triggers to flare-ups in their diet and what they should be looking for on remission. Isabel, over to you. When you have conversations with your patients, do you, how do you talk to them about trying to identify those food triggers?
Yeah, it's a really common conversation when people are living and feeling well with Crohn's and colitis. I think one of the worst things is the loss of control and not knowing when this flare-up is going to happen and when I'm going to get unwell again and in what position and where will I be. And often trying to control your diet just isn't obvious, isn't it? It's one way they can try and do something different. And I think the problem, a bit like Katie and Sham said, is there just isn't an absolute clear answer. I wish I could give everyone a diet sheet that would keep their Crohn's and colitis in remission, but we just don't know. I think it does vary, and it's really important, particularly when you're well, or if you're newly diagnosed and just recovering from your first flare, is to really talk with your team. It doesn't need to be a dietitian, with the gastroenterologist or with the nurse specialist, and just have that conversation right at the outset, because it is slightly different depending where the inflammation in your bowel is, and there may be some particulars that they can describe to you. But generally, I think it's about going on that journey that Lizzy and Nell talked about, that if there are foods that obviously trigger things, you quietly learn those over time, perhaps avoiding really excessive stimulants. I think Lizzy talked about it, lots of fibre, lots of spices, 10 pints and a curry, those sensible lifestyle things. But there isn't a hard and fast answer that we can give you. There is really an important thing though, which is always to make sure, whether it's your GP or your IBD team, that you've had a check for celiac disease, because there is a link between particularly Crohn's disease and celiac, and it's really easy to check for, and that's a formal reaction to gluten, and it's always important to just check that you've had that done at some point.
Great, thank you, Isabel. So now you mentioned, that how you sort of went about identifying food trigger, and in fact you've gone gluten-free, haven't you? How did you alight on that? Did you look at any other food triggers, and have you had a celiac disease test?
I actually haven't had a celiac disease test.
No.
That's on my list to do now. But yeah, so I stopped eating gluten when I think it was about when I was 17, so it was like 4 years into my diagnosis. And I think I just noticed that every time I ate bread and pasta, like I felt really bloated and it triggered ulcerative colitis symptoms. I also thought for a bit it was dairy, then I worked out it wasn't dairy, and then I realized it was sugar. It was a lot of like, it's something, couldn't work out what it was, cut out that thing, then it worked out that's fine, or do you know what I mean? A lot of cutting and adding back in. But yeah, gluten for me is a no-go.
Were you keeping, a diary or something? How were you sort of monitoring what was going on?
It was more just like listening to my body. So like I would just feel bad after when I eat something that's bad for me. I feel it straight after, or like a few hours after. And I think it's just really important to like listen to that and respect that, and be really honest with yourself about that, which is really difficult with diet because you want to eat normally and make it as easy as possible, which has definitely set me back multiple times. But once you just like give into it, it does make your life a lot easier. So yeah, giving up gluten was a really good way to kind of maintain a bit of control.
Interesting. And Lizzy, you've gone even further. So you've also cut out dairy and you've been on quite a journey. So how did you go about identifying what was triggering you?
So when I was first diagnosed, my consultant suggested I cut out dairy, spicy food and alcohol. And it used a similar line to you, Isabel, don't go out for a curry and 10 pints. So I did that straight away, gave up dairy straight away. I then, went on quite a journey with it, where I was keeping a food diary, and I was keeping quite a kind of a lengthy food diary where I was writing down not just what I was eating, but also exactly how I was feeling. And I put a lot of detail into that, because then that really helped me to kind of make those links, and I could see what foods I was eating, and and the same scale pain or symptoms that I was getting after certain meals. Saying that though, I did get it wrong, and for about 18 months I was eating kind of pastas and like mild kind of chilies and curries, pies and things, and was getting symptoms. So I then decided that it was onion that was my problem, and then I wasn't really seeing any improvement. And then in summer last year, about June time last year, I mentioned to my consultant that I was really struggling with bloating, and everything I was eating, it felt like to me, everything I was eating, I was really bloating, and it was really uncomfortable. And he suggested I cut out gluten. So I did that from that day. He suggested that day, and I was so desperate, really. I did it straight away, and it was brilliant. It really helped me. And then my partner actually thought one day, maybe it wasn't onion that was the problem, because I was struggling after eating kind of pastas and things like that. So I started adding onion back into my diet, and I do eat that now. But I did have a test for celiac when I was first diagnosed. So I haven't got celiac, but I do not eat gluten. But the same as Nell said as well, I have different symptoms as well. If I accidentally eat something, I can tell you what I've eaten that have caused those symptoms. So if I've eaten dairy, I can tell you that I've eaten dairy, or I can tell you that I've eaten gluten. I know which symptoms belong to which food that I've kind of accidentally eaten.
So dairy and gluten are probably the two commonest food groups that are brought up in communication with the charity from patients. What is the actual evidence around this, Katie, that linking eating gluten and dairy with flare-ups and the diseases?
I mean, in terms of dairy intolerance, I'd say it's probably more specifically lactose intolerance is often commonly the trigger, especially in Crohn's disease. Recent research suggests between 40 and 50% of people with Crohn's disease actually have lactose intolerance, which is higher than we previously thought. The incidence in ulcerative colitis is slightly higher than the general population, but much lower than that. So there definitely is, a rationale and a reason there why a lot of people are saying that dairy is a trigger for them. In terms of gluten, I think we also need to be careful about distinguishing between gluten and another sugar found in gluten foods. Some of you may have heard of the low FODMAP diet. So there's a specific fermentable carbohydrate found within gluten-containing foods, which does commonly trigger gut symptoms. So it might not be gluten per se, it might actually be the sugar within those specific types of carbohydrates. In terms of identifying triggers, I think it's very, very important to always read challenge as well. because when we do initiate food exclusions, it always is followed up by reintroduction, because it's very important to know what your individual threshold is to that food. So it may be that you can't tolerate it at all, but the likelihood is, in my experience, patients can actually reintroduce foods to a certain level. And when it comes to gluten or wheat-based foods, they are digested in the body differently. So pasta, for example, is digested differently to cereal and it's digested differently to bread. So we'd actually recommend retesting them all separately. And you might find that you can actually reintroduce some, form of gluten and don't need to restrict it completely. The other concern with dairy is that it's a very good source of nutrients. So if patients are avoiding dairy, it's very important to replace that with an alternative, so calcium fortified alternative. I don't know if the panel members want to mention whether they are using alternatives, but I think that's also something very important to consider when cutting out food groups.
I take a prescription calcium twice a day.
So it's interesting, Lizzie, in your case then, and you've gone through, as you say, quite a journey in terms of trial and error, exclusion, and some re-challenge. Were you working with an IBD specialist nurse through that, or a dietitian, or were you doing that on your own?
I didn't have an official dietitian, so I was diagnosed just weeks before the first lockdown. So I feel really lucky that I got my diagnosis just in time, because it meant that I got medication, and I know a lot of people struggled in that time. But the IBD nurses at my hospital are brilliant. They answer the phone and emails, and I spoke to them at length about it. I had regular calls from my consultant and also my GP. So my GP, and in those first few months, my GP would ring me every week to check on how I was doing, and I'd talk it through with her. And she was brilliant. She was really supportive, and she really helped me.
Wow, I want that GP. She's great.
She's unfortunately not my GP anymore, but yeah, she's brilliant.
Okay, and what about you, Nell? Were you working in partnership with your clinical team on this, or did you work it out for yourself?
It was more working it out for myself. So I was 13 when I was diagnosed, so I don't remember too clearly about who helped me out when I was diagnosed. But when I got to 17, 18, I went to a nutritionist who stripped back everything on my diet, and then we restarted again, started introducing things, which really helped me and kind of helped me begin my journey of working out what I could eat.
And have you tried the Rechallenge approach that Katie was talking about?
Yes, I have. I find it quite difficult because I love to eat, so I found it quite difficult to do things I don't know, I guess responsibly, but I did do that, and I did work out a lot of foods that triggered me really badly, which was interesting and sad, but good.
Great. Okay, so just thinking about in terms of the other diets that are around. I mean, Katie, you mentioned FODMAPs. That's quite a challenging, complicated diet, isn't it? It's not easy to undertake, certainly on your own. What's the advice there around? Is that being used a lot with patients with Crohn's and colitis, and how much research is into that and the link to, again, having Crohn's and colitis and flares?
So the important thing about the low FODMAP diet is it's only a diet which we initiate in clinical remission. So it's more for what we call functional symptoms. So most of the research is actually in another condition called irritable bowel syndrome. So we do have quite a large body of evidence. So we use it very routinely in clinical practice. There is also research specifically in patients with inflammatory bowel disease in clinical remission, and they've shown a good symptom response. The only caution I would give in terms of using it in inflammatory bowel disease is when in these studies, when they've taken stool samples and they've looked at the gut bacteria, unfortunately the diet does cause a reduction in beneficial bacteria within the gut. So we don't know about the long-term risks, and that's part of the reason why I was explaining the importance of always rechallenging foods back in and not, you know, continuing on quite restrictive diets long term, potentially unnecessarily, because of the you know, the potential long term risk from that side of things. But yeah, it's primarily used for more what we call functional, so bloating, abdominal discomfort, diarrhea, not related to gut inflammation.
Yeah. Okay, great. Thank you. So often people, especially when they're trying to manage their condition, especially in the early days, they might end up with a very basic level diet. Sham, if one of your patients was, you know, really having quite a basic diet, what advice would you give to them? How would you manage that kind of patient?
I think, first of all, it's important to recognise that that's a pretty horrible position to be in as a patient. I mean, if you've got IBD, you've got a flare, and anything that you eat makes those symptoms worse, that's a pretty bad place to be in. And so I guess the first thing would be to try and work out what the cause of those symptoms are. And it's not just diet, we need to look at the whole kind of medical plan. So if there's active inflammation in a specific area of the bowel, we need to target that. Are there any narrowings or strictures within the bowel that are contributing to the symptoms? So we need to try and get a kind of proper management plan in place so that we can manage the symptoms. But in parallel, in terms of diet, you know, when it's bad, patients often find that lots of different types of food groups are contributing to the symptoms. And in that scenario, often when patients are unwell, they've got lots of inflammation, their energy requirements are going to be a bit higher. We know that in patients who flare, their energy requirements are a bit higher than when they're in remission and the general population. So we've almost got a sort of a double whammy here. You know, you've got patients who can't eat as much, but actually need a bit more. And so in that initial period, the sort of normal, healthy, balanced diet that we often talk about tends to go out of the window, and we tend to focus a bit more on kind of calorie-dense foods to try to meet those requirements. And so we need to think about kind of, you know, carbohydrates, proteins, and fats actually to be able to meet those energy requirements on a daily basis. And there's various ways to do that. There's, you know, we talk about food fortification. So things that you like, so maybe changing semi-skim milk in your tea or coffee to full-fat milk and cream, extra jam and marmalade on your toast, really in that initial period to try to, I guess, meet those energy needs. And then hopefully, as you know, your treatment plan kicks in, your symptoms start to wane, you're able to increase the repertoire of foods that you can eat. You know, that would be my general approach. And the last thing I'd say about that is it's really important for us to not just think about dietary therapy and medical therapy, but the nutritional status of the patient overall. So are they undernourished? Are they overnourished? What can we do to normalize that? Because actually that's also really important in our IBD patients in terms of outcomes.
Great, thank you.
We do need to test Nell for celiac disease at the end of it.
Definitely. Okay, Nell, after your test for celiac disease, which is going to happen immediately, you do a lot of work around food development and recipe development, don't you? And for many people, you know, when they've been really ill and they're very anxious about eating, you know, different types of food. And it's, as Sham said, it's really important you get good nutrition in. What do you have any tips about how to make things taste better to get people, you know, sort of happy to eat again?
Definitely. I think for me, the hardest thing with having ulcerative colitis, especially when you're having a flare up, is that you can only eat certain foods, and that is obviously very boring. So for example, for me, like fish and white meat is fine, and rice is fine, and like gluten-free pasta is fine, and herbs are fine. So I would find a way, like 2 vegetables are fine. So I would like find a way where I'd like fry the vegetables and then at the next meal grate the vegetables, or like roast the chicken, fry the chicken, just like try out different ways of cooking it, different grains to put it with, just to like give yourself a bit of variety instead of eating the same thing every day for every meal, because that's just quite depressing. So for me, like, lots of herbs are fine. So I would just like to give my food flavor, I'll put loads of herbs in them, season it really well. I can't do spice, but I can do kind of like turmeric and more like not spicy things, but I can use some spices that are, they have actually good properties for your stomach. So I'll like put tons of that in. So I'll just find ways to kind of like use all the ingredients that are good for my stomach in a more imaginative way and experiment with them a little bit. And it might not always be nice, but at least you're not eating the same thing every day. Yeah,
that's great. Thank you. So just thinking in cases where, you know, sometimes things are pretty bad and people have ended up on a liquid diet. Katie, just from your perspective, what tips would you give to someone who is on a liquid diet and how to manage that particular scenario?
Yeah, so I presume you mean exclusive liquid nutrition. Yeah. So my main experience in this area is with adolescents. So we do use it as first line treatment compared to steroids, which has got a lot more side effects and can affect bone health and growth. As you can imagine, in that age group, there are quite a lot of challenges. Patients going to school, they might be going to college. You know, there's the social aspect of it as well, feeling excluded at meal times, not wanting to appear different in front of friends. So it is quite challenging. I think one of the main things is educating the patient and the parent over the reasons why we're recommending this particular type of therapy, getting everyone, you know, within the family on board, the whole multidisciplinary team as well. Within the hospital. So if the consultant, as well as the specialist nurse and the dietitian, are all encouraging this specific treatment, we tend to get more successful results than if, you know, there's conflicting advice. The other more practical aspect is finding a drink that, you know, the patient can actually drink, so that the taste of it. So usually what I would do is I'd give the patient a few different samples. So different products. The evidence at the moment is that, you know, we can offer any type of prescribable drink, whether that be juice style, milkshake style, or powder version. So whatever suits the patient, really. There is more evidence for a specific powder-based product. I'm not sure if I'm allowed to mention names on the chat. But we do tend to use that just because there is a bit more research for that particular product, but it might not be practical for, you know, someone to be making up a feed and decanting it into a bottle. So if that isn't going to work, then, you know, we can give pre-mixed formulas. So providing them with lots of different flavors. It tends to be tastier if it's been in the fridge. So definitely encourage them to chill the drink and not have it at room temperature. In certain cases, if they can't manage the full volume needed to meet their nutritional needs, we can provide feeding tubes. In my experience, we haven't needed to do that very often, but that is an option. We can give patients temporary feeding tubes to supplement their oral intake if they can't manage it all to drink. But yeah, I think the key is just to try and be flexible. They need a lot of support as well. I don't think you can initiate a liquid diet unless you've got the full support of a dietitian and regular input, including telephone reviews in between clinic visits, you know, to answer any queries or questions or provide any support in between. I don't know if there's anything else Sham would want to add to that, but yeah, that's my experience.
Thank you, Katie. And I know I mentioned at the top of the meeting that Nell has to go a little bit earlier away. So I'm just going to give you one last opportunity, Nell, before you need to leave. Are there any top tips or anything else that you'd just like to share with our audience tonight?
Yeah, I think my main one is just to be patient and respect and listen to your body. Don't be hard on yourself. And it's a really hard thing to live with. So just like remember that and just try and listen to your body, basically. I feel like that took me a while to learn, and I'm finally at that stage, and it like feels quite like liberating in a way.
And it's a good life to be led.
Yeah, exactly. It's not,
right.
It's bad, but it's not terrible.
Thank you, Nell, and thanks for joining us this evening. So just moving on to a slightly different topic then, in terms of living with Crohn's and colitis, you know, people have to have a normal life. You know, they need to move around, they need to go on holiday, they need to go to work, and etc. So, Lizzy, what's your experience of, you know, sort of trying to manage your diet on the move, on holiday? How do you approach it?
I think in terms of eating out, you just need to be upfront, and you know, you need to be honest with, you know, the people around you, your friends, your family. And you know, there's a handful of places locally to me who I know cater for me, and I know, you know, I can have some really nice food that my body does agree with. So you know, just kind of speak up, and if you want to go somewhere, and if there's somewhere that you're going to enjoy yourself as well, then, you know, speak up and go there. I was definitely guilty of not speaking up because I didn't want to be the awkward one. And I didn't, you know, in my group of friends, and I went to my friend's wedding last year, and it was the first time that I felt I had to speak up and be awkward and say, oh, I'm sorry, I've got these dietary requirements. But you know, everybody is brilliant, and everyone's understanding, and you know, it's our body, it's our health, so it's really important. And yeah, I did eat things that I knew would upset me, because if somebody had cooked it for me, and then I'd feel guilty to say, oh no, sorry, I can't eat this, and then it'd make me ill, and it's just not worth it. So I think speak up for yourself, and just know what works for you, and the people around you will support that. In terms of traveling, so I went to Paris last week, which was the first time I've traveled since diagnosis, or first time abroad since diagnosis. It just takes a little bit more research. I researched before I went of you know, gluten-free and vegan places. Really, when I'm eating out, I find it easiest to eat vegan, because then I know 100% there's not going to be any dairy in it. Some of the, you know, if you don't eat vegan, there might be some butter in a sauce or something like that. So yeah, I did my research into gluten-free and vegan places in Paris. There's, you know, groups on Facebook, gluten-free groups, that I did a Paris search. So it just takes a little bit more kind of planning and a bit of research before you go. You can't be quite so spontaneous. But it worked really well, and I ate some really good food, so it's worth it.
Great. I think there's been an absolute sea change, hasn't there, in the last 10 years in terms of availability of foods which are, you know, responding to the gluten-free diet or to a dairy-free diet. So things have improved, but it's such a social thing. It's how we kind of, everything that we do as human beings, you know, food and is a kind of gift and offering. So it becomes really difficult to negotiate that socially. But I think it is becoming more acceptable, and if people are able to feel they're honest about their health and it's a health issue, then there is more acceptance. So I'm glad you made that point. Thank you. Just had a question in, and so about the liquid diet that we were talking about earlier, Katie. So we're just going to go back to that, and somebody's just asked, can they ask their consultant to treat them with the liquid diet rather than going on steroids or of course, medication? Do people do that? Is that reasonable?
I mean, in my practice, if a patient has requested to trial a liquid diet, then we should trial it. However, it would need to be assessed on an individual basis. It would also depend on how severe their disease is. Most of the evidence for liquid diet therapy is for mild to moderate disease, not more of the severe end. So as an alternative to steroids, I would personally say that we could use it. Sham may want to feed in here as well. But I think it would need to be assessed on an individual basis.
Sham, what do you think? Do you get people asking you?
Yeah, I mean, in answer to that question, patients should be able to ask their consultants anything. As Katie says, it's really dependent upon the patient's kind of specific clinical situation. I guess the first thing to say is that there isn't any evidence for a liquid diet at this point for patients with ulcerative colitis. There is evidence, sure, in patients with active inflammation in Crohn's. That's probably important to say. And there may be very good reasons why your medical team might prefer steroids over a liquid diet. So it's absolutely right to say that. But as Katie says, you know, there is good studies that show that a liquid diet can be as effective as steroids for adults with active inflammation in relation to Crohn's disease. One thing I would just say in terms of the previous discussion about quality of life, I think there's a lot of information or studies looking at other aspects of quality of life of patients, employment, relationships, and so forth. But food-related quality of life is such a big area that I think merits kind of further study and further information. We know that some of the work already shows that patients with IBD have a worse food-related quality of life, and as a result are often deficient in certain food groups like calcium and fiber. So I think, yeah, that's a really big area for us to perhaps focus a bit more on in terms of research and work over the next few years.
Just following on from that then, Sham, about, nutritional deficiencies. I mean, it's a really important area. Do you think people should be screened for nutritional deficiencies?
Yeah, so this is important. And I think the distinction to make here is that we're now talking about nutritional status and nutritional therapy, which is a bit different to dietary therapy. So food and diet as a primary therapy for IBD, as opposed to improving your nutritional status. But it's still really important. And it's important because undernutrition is common in IBD patients. Up to a third of patients have some level of undernutrition, and that can manifest in different ways. And we know that that's also the case for patients in disease remission. So just because you're well and in remission doesn't necessarily mean that you're not at risk for various nutritional deficiencies. And that might be being underweight and undernourished, but also having some micronutrient deficiencies, vitamin D, iron, are sort of common things that we think about. So in answer to your question, this is absolutely the case that we should be screening or thinking about nutritional deficiencies in our patients, which is why even if we have patients that are relatively well and are coming perhaps once a year, we do that annoying thing of asking you to come for blood tests. And that's because we know that even if you're feeling well, we may pick up an iron deficiency or a vitamin D deficiency that requires replacement. Great.
So I mean, one thing that sometimes happens is that people, they look to make up the deficiency through supplements. Would you recommend people taking supplements in any case for certain things? I mean, vitamin D is the common one, isn't it? Would you recommend that, or just say no, basically talk to your team before doing anything like that?
Definitely talk to your team. So in general, if you have a healthy, balanced diet, your gut is functioning, you're in remission, it might be that you don't need any supplements and you're getting everything that you need through food. And that is really what we want to be aiming for. But you're absolutely right. In some instances, for example, vitamin D is the one where all of us, regardless of whether we have inflammatory bowel disease or not, should be on some vitamin D supplements through the winter and autumn months. And there's some evidence that actually IBD patients probably need a bit more in terms of dosing. But so in general, ideally not, but it is definitely something that you need to speak to your IBD team with, ideally with a set of blood results to inform that discussion.
Right. And then when you come out of a flare and you're going into remission, people might want to introduce more more fibrous products, fruit and vegetables. That can be a bit difficult. And Lizzy, I mean, just from a practical perspective, you know, how do you go about, if you have gone through a flare, how do you go about reintroducing a wider range of foods that might have been problematic with a flare?
So one thing I found really useful was smoothies and soup, both homemade, so you know exactly what's going into it, but it just enabled me to get that fruit and veg into my diet, and my stomach could digest that a lot easier. So I, for quite a while, would just blend most of my food. One thing to note, and just to be careful that I actually got to the point where I wasn't taking in enough calories doing that. So just a side note, make sure you are taking in enough calories doing that. But yeah, my body can digest fruit and vegetables in kind of smoothie and soup form a lot easier. So yeah, that's what I tend to do when I need to reintroduce them.
Great, thank you. For those of you who have noticed, Isabel has just gone on to her name, and there has been a power cut at her hospital, we've been informed. So you may have noticed she seemed very still for a while. We were hoping that she would just miraculously come back in, but sadly, it looks like maybe she is. So hopefully the power cut has been solved, and there she is. She's back in the room and with us. Fantastic, thank you. Isabel, while you're here actually, and I'll get this question in just in case the power goes, again, people often want to get, to speak to an IBD specialist dietitian. When you get patients, how do you sort of advise them? Are you able to advise them and direct them in that respect?
Yeah, I think there's two prongs to that answer, really. So the first is, we know, and you know from the work that IBD UK do, that there just aren't enough specialist dietitians across the UK for working with IBD teams. But I hope what this evening has really shown is that actually the team in all its richness can often answer a lot of people's questions. The gastroenterologists and their specialists, the groups, whether that's a patient panel or your local Crohn's and Colitis UK network group, and certainly the information, and I think it's one of your most popular publications, isn't it? Certainly is with our patients, the Food and IBD guide that Crohn's and Colitis UK have is just superb. So absolutely, there's lots of other ways to answer your questions and to share and to get information. But yes, we're lucky, we do have some IBD dietetic support, and certainly we also do with people who have an irritable bowel syndrome. So when Katie was talking before about FODMAP, so we can access it, but there are lots of other members of your team who can hopefully answer your questions too.
Thanks, Isabel. So we've been talking very much about very specifically about Crohn's and colitis. Now, often people don't just live with Crohn's and colitis, they have other conditions. And we've had somebody who's asked about what you can do when you have other dietary requirements. And this is in the context of having diabetes and perhaps it feeding through a tube as well. So should we go, let's try Katie first, and then we'll go to Sham, see what you've got to say on that. Tricky conditions.
Yeah, I mean, I think the key really is working as a team. So always liaising with your consultant. We do have other specialists within the hospitals. We have diabetes specialist dietitians as well. So if I had a patient with, with complex disease as well as diabetes that may be on insulin, you can always have shared care. So I may see that patient for the gastroenterology issues, but then I may also refer to my colleague who's a specialist in diabetes and blood sugar management. So I think the key really is just collaborating with your colleagues and sort of working with the team. And it may be that there's different issues at different stages as well. So if you, this patient with Crohn's disease, diabetes, feeding tube, it may be that different specialists needs to be involved at different periods of time as well. Also liaising with the community dietitian. So if they're on a feeding tube, we would need to involve community dietetics as well, and community nursing teams. So I think the key really is just trying to collaborate and involve as many specialists as is needed.
Yeah, it's a complex problem needing a multidisciplinary approach. Yeah, Sham, have you got anything you want to add to that?
Yeah, I think that's exactly the right approach. It's really difficult, and this sort of reflects real life, doesn't it? Because patients have lots of different problems, and many of the things that we've discussed today can be quite challenging in real life, particularly when patients have other issues. So there are some instances where some of the things that work for IBD also work for other things. So diabetes, fiber, healthy balanced diet, that's really relevant for both of those conditions. But Katie's absolutely right. It's really individual, and it really does rely on good communication with your team and then others as necessary.
So we've got 5 minutes left in this session. I'm going to just ask hopefully some very quick questions just to finish off, and then we will just have a quick roundup. So who should I give this one to? I'll give this one I'll give it back to Sham. Should I change my diet after surgery?
Okay, so that again really does depend a bit on the detail. So it depends on what operation you've had, what bowel is left, whether it's normal or not. And so in general, for example, it might be that you've had an operation to remove a narrowing within the bowel. That's pretty, one of the most common reasons to have an operation. Might have been, for example, that you've had a low fiber diet prior to it. And so really, if you've had an operation, the ideal is that you're able to increase the types of food that you can eat slowly over time. That's one example. But it really does depend on the kind of specifics of where you are at that point. I think the other thing I might say about that is also quite important in terms of what you're eating and nutrition before an operation as well, because we know that your nutritional status going into an operation is one of the most important predictors of how well you'll recover afterwards. And so, improving your nutritional status going into an operation is as important, I'd say, as what you have afterwards.
Thank you. And then I've got one last question, but I'm going to actually get Katie, Isabel, and Lizzy to answer this one, because I'm sure it's one of the things that people get asked a lot or told a lot. So if somebody, I'll start with Katie. If somebody is saying to one of your patients, diet is the answer to this all, what would you advise that patient?
Is this in relation to sort of diet curing the condition or just managing it?
Well, cure, let's go for the extreme. Let's say cure.
Yeah, I mean, sadly, unfortunately, we don't have a cure, whether that's medication or diet at the moment. I think the important key is just trying to follow as healthy a balanced diet as possible to try and improve your nutritional status, as Sham had said, to help to keep you in remission for as long as possible. Try and enjoy your food, try not to exclude food groups if it's not necessary, or it's not triggering your gut symptoms. There's no evidence at the moment that there's any food you have to completely avoid. So just try and have as balanced a diet as possible. But yeah, unfortunately, we don't we don't have a cure at the moment. There's a lot of interesting research coming out, and we hopefully are getting to a stage where we will have diet as therapy. Certainly, we're getting there with Crohn's disease, but it's not going to be a one-size-fits-all, unfortunately, just like it is with medication. Everyone has to be assessed on an individual level. But I definitely think there is a role for diet in the management of inflammatory bowel disease. And I think sometimes it is underplayed. So hopefully through all the research that's coming out now, it's becoming a bit more high profile, and it is actually being recommended a lot more.
Thank you. Isabel, when patients come to you, especially early on, perhaps very anxious, being told many different things, and somebody comes up to them and says, just change your diet, How do you support them in that?
I mean, it's just so common, Sarah, especially when people are newly diagnosed. You know, Auntie so-and-so tells you not to eat gluten, and, you know, and people want to help. They want to be able to, and it just makes sense, doesn't it, in our minds that you should be able to really change what you eat and really change how you feel. And I think Nell's advice before she left is absolutely right, which is everybody is individual. Listen to your body and react to what your body is telling you. That they, you know, it may be depending where your inflammation is and how severe it is at the time, that we can give you some dietary guidance. But if other people, it's just about being clear for you as an individual and working that out yourself with our support. And Lizzy, I'm sure, will add in, but people do it out of kindness. They want you to see you better, and they think that that's an easy win, you know.
Yeah, thanks. Lizzy, over to you. As patient, should have the last voice on this. What would you say?
Yeah, I mean, everybody's just got your best interests at heart. And, you know, so and do listen to people. And you know, when I was first diagnosed, I read everything there was to read about colitis. It was, you know, it was quite a shock to me. It was about 2 months really from first kind of getting ill to being diagnosed. So I read everything on the internet that there was about colitis. But yeah, you've just got to do what works for you. And, you know, just listen to your body. Do listen to other people. You know, they are trying to help, but at the end of the day, you're the one that's experiencing the symptoms. You're the one that knows how you feel as soon as you eat something, and you do, and you eat something, and some foods within a matter of minutes, you know whether it agrees with you or not. So you know, listen to your body and kind of make the decisions for yourself and for your own health.
Patient is in charge. Thank you, Lizzy. So there's been a fascinating discussion this evening. Thank you very much to my panel. Some really excellent insight there, and I hope everybody's found it useful and stimulating. Of course, there have been links being put in the chat, so to various websites, which hopefully you'll find helpful, including the charities, which has had a refresh, so it's looking great now, and lots of exciting information there. Thank you everybody for joining. We always want to make these sessions better, and we do that by listening to feedback. So we have got a survey link in the chat. Please do take time to give us some feedback so that we can continually improve. Hope you've enjoyed it. Hope you join us again next time. Thank you very much, everybody. Have a good night.